This podcast is intended for educational purposes only and is not medical or legal advice. Always follow your local policies, procedures, and protocols when functioning in your respective profession. Additionally, the views expressed by the speakers and owners of this podcast are their own and do not represent the views of their respective employers. Listener discretion is advised.
Alert Medic 1 response.
Ken, Josh, and Mustafa here. Welcome back to the Alert Medic 1 podcast.
As my cat almost topples the camera over. One of many cats. Yeah. All right, welcome back, everybody. This is Mustafa with Alert Medic 1. Very excited to have Dr. Paul Singh with us today to discuss thrombectomy and a few other topics related to stroke treatment. Josh is going to be joining us in a bit. But first, Dr. Singh, just wanted to give you a moment to introduce yourself, tell us about who you are, where you come from, and so on and so forth.
Sure. Thank you for having me, first and foremost. Always love talking about stroke, always love getting the word out, and especially when it comes to thrombectomy. It's a passion of mine, of course. So I am currently the director of the Comprehensive Stroke Center at MedStar Franklin Square Medical Center here just outside of Baltimore. I am also the director of neuroendovascular surgery. And neuroendovascular surgery are the group of physicians that perform clot removal or thrombectomy for.
And how did you get to where you are today? How did you get into medicine? How'd you end up here?
So, I stayed at a Holiday Inn and then I decided that I was cut out. No, I'm just playing. Actually, it was funny. When I was in medical school, I wasn't really sure what I wanted to do, like a lot of people. And this was quite a bit of time ago. And back then, stroke is not what it was. But I'd rotate through neurology, neurosurgery. And I saw a patient that came in with stroke symptoms once, received an IV clot busting medication. I didn't know anything about it at all. And the next day, they were normal. I said, that's amazing. I've never seen like this, anything in my short medical career. I said, let me learn a little more about this. And I realized there was a lot going on in research and development and innovation in this specific field. And I learned more about it. And I realized it's what I wanted to do. I wanted to make that immediate impact from my background in education I could ascertain at the time. And I want to do that long term. Because for me, it's trite to say, but I wanted to work in something where I wouldn't feel like it was a job, but something I'd be passionate about day to day and helping people.
Sure, and certainly the immediate impacts of thrombectomy specifically are jaw-dropping to me. I was first exposed to the idea of a thrombectomy at the Maryland MTAC, it's called the Mid-Atlantic Transport Conference. And it was a gentleman that came in that they had flown in and talked about, what thrombectomy was. And the biggest thing that amazed me was the number needed to treat. Now, actually, I should probably let you explain. If you could just go briefly into what a number needed to treat is, sure, and then what the number needed to treat for thrombectomy is, and then I'll explain why it was so jaw-dropping to me.
Sure, and I think your cat's interested too. That's
yeah. He's not leaving anytime soon. He's a cool buddy though. Yeah.
No, it's funny because back then, when I described that IV medication for stroke, thrombectomy didn't exist. It wasn't a thing. On cardiology, obviously it made sense, removing a clot from the heart, leading to a heart attack, restores blood flow, but it didn't exist on the neuro side. It was very theoretical at the time. And even in the next decade after that, it was not the standard of care. There weren't devices out there to actually remove clots. The R&D hadn't happened quite at this point. To even enter the realm of thrombectomy right now, as far as how you and I would describe it, on that. So it's worthwhile to realize that the history of this is, in the grand scheme of what medicine is actually relatively recent on that. And you've been doing this for a long time too, so I'm sure you remember the times of before thrombectomy actually.
Oh, absolutely. I mean, so I've been in EMS for about 10 years.
Yeah.
So yeah, it was certainly in the EMS protocol, it was 4 hours, right? And if they were outside of that window, then kind of bad luck.
Yeah. It's funny, actually. One of the talks that I talk about what the care of stroke was, and it was an emergency medicine textbook. And the emergency textbook It said masterful inactivity.
Mm.
Another way of
Wow.
saying doing nothing.
Yeah.
And it's amazing how far we've come. You had those initial IV clot busting medications in the mid 1990s. We have new IV clot busting medications now that just came out that we started using here throughout MedStar in 2023. In the world of mechanical thrombectomy, which I know we're going to really dive into a lot during talk here.
Yeah. And just briefly, I mean, going back to the number needed to treat.
I'm sorry about that.
Yeah, no, you're fine,
So it comes back to this IV clot busting medication to kind of put it into something consistent with what we're talking about here. So number needed to treat is how many patients do you have to administer a medication or do a procedure on to actually get one meaningfully good outcome on this. And when we talk about most antibiotics, it might be upwards of 20, 30, 40 patients that you actually have to treat to get one good outcome. So when we looked at this for ischemic stroke, and we're talking about IV medications, the number needed to treat for stroke, when you give them an IV medication within 3 hours, is 7 or 8. You have to treat 7 or 8 patients to get that one meaningful outcome, which is amazing.
Yeah.
It's still greater than a lot of medications out there. When you give it out to 4.5 hours, the number goes to about 14 or so. So still amazing numbers we're talking about here. When we talk about thrombectomy and how many patients you have to treat to get a meaningful outcome, well, there's a range. And the range is dependent on how soon somebody comes in and how fast you do the procedure. But that number is anywhere between 2 and 4. That's insane. You only have to treat 2 to 4 patients to get a meaningful outcome. That means somebody that comes in, as you know, with a complete stroke, can't move one side of the body, can't speak, can't see. You do a procedure on them, 1 in 4 is going to have a completely favorable outcome, if not 1 in 2 to 3.
And that's what was mind blowing to me. I mean, I want to say the number needed to treat for aspirin, and I looked it up, but I don't really trust this source. But for EMS, for some context, right? When we think about someone having an MI, right? The biggest thing they say is, listen, nitrates, sure, for comfort, but they don't really, show any huge positive outcomes. What does show outcomes? Early PCI and aspirin administration pretty early. And that number needed to treat that I just found through an ancillary Google search is 40, right? So comparatively, you need to do what? If you do 3 thrombectomy procedures, that's the number needed to treat. Now, people should understand this is a statistical measure, right? It doesn't actually mean that you got to hit the the slot machine every time, and maybe people get better, maybe they don't. The effectiveness is so impressive, and it's why we wanted to bring you on so that EMS clinicians can learn more about the inclusion criteria for these patients. And why it's such a benefit. So I wanted to transition to, let's talk about briefly, if you don't mind, and we're going to have Dr. Barajas and Lindsay, their episode should be publishing before yours about the basics of stroke, but if you could just briefly talk about the basic types of stroke and where thrombectomy fits in.
Sure. Absolutely. I won't get into the nitty gritty of prevalence and incidence because I think they'll probably talk a lot about that. But what I'll say is that, there's 2 major types of stroke. There's ischemic or non-bleeding strokes and hemorrhagic or bleeding strokes. And for you guys, I'm preaching to the choir. I know that those are the 2 types. So you need a CAT scan typically to decipher between the 2. And when we're talking about thrombectomy, we're talking about the ischemic stroke, which accounts from about 80 to 85% of all strokes. And thrombectomy specifically entails with a subgroup of those ischemic strokes that have a clot that travels to a large blood vessel in the brain. That large blood vessel, the moniker we use is large vessel occlusion. And the one that we've used more frequently since 2015 is ELVO, emergent large vessel occlusion. We actually came up with this acronym, ELVO, in one of our society meetings. We were sitting around a table and we needed something that was kind of like STEMI, something that rolled off the tongue, something that EMS would like, and something the community would know. And we went around the room. We had LAVO and we had ELVO. And this meeting was in Nevada, where Elvis was commonly associated with. And so we went with ELVO. We said ELVO is going to work out better for us, and it hung. So we've done a lot of research on it, and that's what we're looking for. We say the subgroup of patients with ischemic stroke that get thrombectomy, they have an ELVO in the brain. And the large vessels are typically the internal carotid artery, the middle cerebral artery. Those are the largest ones in the brain. But also, as the years go on, we're doing it in other vessels that aren't as large. So they might not be large vessel occlusions. They might be medium vessel occlusions. And those are the anterior cerebral artery, the posterior cerebral artery, the basilar artery on that as well.
So when you're looking at a candidate, I just wanted to welcome Josh. Josh, thanks for joining. When you're looking at candidates for thrombectomy, what are you looking for? And then maybe we can talk about what EMS, at least in Maryland, looks for.
Sure. So we want a significant disabling deficit. And our monitor for disabling deficit, we do with the NIH stroke scale. It's a 42-point scale that essentially measures strength, speech, ability, cognition, sensory deficits, coordination, a whole gamut of things, with higher numbers being more severe. So the higher the number, the more severe the potential stroke is, and the larger the blockage is as well. So we actually use that scale as a surrogate to figure out where a clot might be. So if that number is 6, it might be a large vessel or a medium vessel occlusion. Now, the Cincinnati scale is also used in the field, as you know, and that can be another surrogate for that. And then when you take it together, there's other scales out there, such as LAMS. And the LAMS is another way to say, are there symptoms of a large vessel occlusion versus a small vessel occlusion? If the LAMS score is high enough, usually we say 4 or greater, it might be a large vessel occlusion. And those are the patients that need to get to a center that has thrombectomy capabilities. So if there's the difference of a primary stroke center and a thrombectomy center that are both within 30 minutes, you should go to the thrombectomy center with a higher LAMS score or a higher NIH stroke scale. Again, you don't know if somebody's having a bleeding stroke or a non-bleeding stroke, but if you play the odds and 80 to 85% of strokes are ischemic, it's still the right thing to do to go to that thrombectomy center. Josh, it's nice meeting you as well.
Nice meeting
sorry
you too,
I missed
Doc.
you initially.
Sorry, yeah, I had some family responsibilities to handle. So obviously coming in, I don't know, 10, 15 minutes into recording, maybe less than that. I don't know. But so talking about the thrombectomy and capable centers and using Cincinnati and LAMS in the field, and how LAMS with that score of 4 greater is really pushing towards that large vessel occlusion. Why is it that even though LAMS and Cincinnati share a lot of properties, Cincinnati is simply a positive and LAMS is a actual numbered scale, and it can drive us to certain places? What's that like defining line? Because I'm sure there's someone out there, at least in Maryland and maybe somewhere else, that's using LAMS and Cincinnati's like, well, one's a number and one's a positive negative. Why exactly are they so different, and why do they push care in one direction over the other?
Yeah, no, it's a great question. I'll be honest. It's funny. There's so many scales out there. LAMS is just one of numerous scales that we use clinically to determine whether something may be a large vessel occlusion. And Cincinnati is actually not clinically used in the hospital, as you know. We use NIH stroke scale. So it's funny because if you were to go into the field and say, can you get a stroke scale, it might not happen. But if you go into the hospital and say, can you do a Cincinnati, it's not going to happen either. So the intersection, I feel like, are a lot of these large vessel scales, which have been developed, such as LAMS. And I think just from a pure knowledge base, everybody in the ED knows what that is. You guys know what it is as well. And that's the one that's been thresholded and studied for the field. Whether it's that, it's race, it's van, there's so many, again, out there. It's just the field it's just the score that's been studied as a thresholding for large vessel occlusion. And I will say this. As we're talking about medium vessel occlusions that are going to be on the horizon now, the LAMS score that we've traditionally been using is going to change. It's not going to be that threshold forever. I anticipate that we're either going to be using modified LAMS scales. We did that in New York when I was in practice there as well, or just a lower threshold.
So what does that look like though? When you say lower threshold, like would it be like a score 2 instead of 4, or like is it something else?
Yeah, exactly. So in New York we use LAMS plus speech. It was a LAMS score plus a speech added on there as our 4 threshold. So that might be another way to do it. But the question is, when somebody has a medium vessel occlusion, their score may not be as high. So maybe it'll be a 3 as a threshold. But in actuality, I think what we're going to end up seeing is a new scale. There's new scales every few years. And that new scale is going to essentially help quantify some of those strength areas on there. And it won't be too complicated, because if it's too complicated, it's not going to work. But I think it's going to probably be some sort of new scale on that, because I don't think we have enough literature to say what LAM score correlates with a LAMS of 3, for instance.
Got it. Thank you. So let's go into the actual procedure, if you don't mind. Let's talk about types and, how it's performed, so on and so forth.
Yeah. So the procedure itself is very similar to a cardiac catheterization. When I describe elective procedures to my patients, I try to simplify it as much as possible. But I essentially say all the blood vessels are connected in a giant highway, and we enter that highway through several exit ramps. The most common exit ramp is the one in the leg, the femoral artery. We enter through there, and we navigate small catheters or tubes all the way up to the brain, to the point of occlusion. We use X-rays with high resolution imaging to reach that point. We'll use contrast that's used in CAT scans to better visualize the blood vessels, to see what's actually blocked off and what's not. It also helps us see how blood is traveling and how much reserve each patient has. I'm sure we'll talk about collateral flow at some point in the brain here too. And that helps us gauge that real time, how the blood is actually flowing. Once we have a good diagnostic ability to see what's blocked off, then we go after it. Time is brain, we're flying at this point. We're using several devices. Some are essentially stents on a stick that we put across a clot, then we retrieve it out. Others are vacuum aspiration. It's a very pliable, soft catheter that we're able to navigate all the way into the large blockage in the brain, and then hook it up to a vacuum pump that really gets almost near perfect vacuum, not exact, but pretty close. And then you retrieve the blood clot out of the individual to help restore blood. And then it's funny, if you'll allow me to elaborate a little bit. I was trained by a French physician, and he was an entrepreneur. And he was opening up a bottle of wine one day with a corkscrew. And when he took that cork out, he said, I wonder if I could do this for a blood clot. And one of the very first devices that we used is called the Mercy device, or Merci, thank you in French. And I credit him with this, back in the mid 90s when he came out with it. And I have his patent on my wall, or like a picture of it as well, because it was a game changer back then. But let me tell you this, that number needed to treat we were talking about, that stent on a stick only worked about 50% of the time, 55%. So still pretty good. But the devices we have now work about 75 to 85% of the time for removing a blood clot successfully. So a game changer in the way of how we do thrombectomies. The technology is going crazy right now. Catheters are getting softer. They're getting longer. The devices are getting safer. So the risks of the procedure are going down as well for it. And we're able to restore that blood flow more successfully in hopes that we'll get that favorable outcome for that number needed to treat that we were talking about earlier.
Yeah, and speaking about blood flow, let's talk a little bit about the damage that occurs with stroke, specifically parts that are recoverable, parts that aren't recoverable, and what things like collateral circulation can do to either assist or be detrimental to the patient.
Absolutely. So when we talk about stroke and we talk about the brain, we live by the motto, the dogma, time is brain. And often I'll have an hourglass with the brain kind of pouring out of it in a lot of my talks to kind of put it in real world. In 2006, Jeffrey Saber published an article that we all quote. Every minute that goes by, you lose about 2 million brain cells. And we still use that quote just to say how severe the damage can potentially be if you don't remove a blood clot from the brain. But not every brain's created equal. And even with us sitting here right now, our brains are built differently. They do the same job, but they do it in different ways. If there's a blood clot in the brain, my brain might not be able to take very long before it suffers severe damage. It doesn't have any backup mechanisms where other blood vessels are helping out to that area. Where your brains might have other blood vessels that are already built in with connections there that can supplant the blood flow to that area temporarily. And so, Mustafa, your brain might do it for 24 hours. Josh, yours might do it for 12 hours. But there's no way to actually know that when you come to the ER or when you're picked up by crew. It's advanced imaging that allows us to do that a lot of times, to see what's core, what's already dead, and what's salvageable, or penumbra. And the penumbra is highly reliant on how we're built. Those collateral networks determine how much penumbra is there. I can try to share a screen of what that output even looks like when somebody comes in. And let me see if I can pull it up here for you now, and you'll see it.
Sure. And there should be a share option at the bottom of your screen. Do you see that?
I do.
All right, perfect. Yeah.
Let's see. I'm just going to share the slide. It's not full screen on this, and you should be able to see this. So here's an example here of what penumbra actually looks like. The area on the left that's pink or magenta, however you see it, is an area of core. That's already dead. Doesn't matter what we do from clot removal in the brain, that area is probably going to go on to die based on what we know with the physics of how blood is working in this patient. That area in green, that's the penumbra. That's what's reliant on our backup systems on here. And so that's what we're trying to save. And we like numbers. So on this patient, you can see that the numbers show a massive ratio of 7.9 between those areas that are salvageable and the areas that are potentially dead. You know, these numbers change over the years. When thrombectomy first came out, 1.8 was that ratio. We wanted everything to be greater than 1.8. Now we're closer to 1.2, if not less sometimes, because we're finding more and more patients benefit. But this is a AI-generated software program that many places have different iterations of, so I won't get into the names of what these programs are. They all do the same thing, essentially, at the end of the day, in determining this. And once we see that somebody's a good candidate based on this ratio, we know that they're a candidate for thrombectomy. So it's just one of the tools that we use when it comes to it.
So you mentioned time. I mean, time is brain, as you said, earlier. What's the initial, we, from the EMS perspective, we see a lot of stuff going on as soon as we bring a patient in, right? Could you, talk to us about how it looks on the hospital end and talk to us about the initial, 30 minutes, hour, 5 hours that occurs with a patient that is a candidate for thrombectomy and how that, movement looks throughout the hospital?
Sure, absolutely. So, what you guys do is critical. And like early communication of what we hear before they get to the door is absolutely critical because it helps us mobilize resources very quickly. It helps us put everything else down and work on this because we know that time is brain. And so we need to see this patient ASAP on that. This imaging, you have to have your CAT scans available. You have to have everything in line. So pre-notification is huge to get that in line. So when you guys come through the door, we are expecting a stroke patient. We already have a PIC crew set up. We want to hear the story from you guys again. We want to see how the patient did en route. We want to see if there are any arrhythmias, any blood pressure issues, any relevant past medical history that might change the treatment course with IV thrombolytics. Any history of stroke, any history of bleeding, any history of any coagulopathies. Are they on any blood thinners, for instance? Anything major, we need to get ASAP. That history is so crucial in figuring out if patients are candidates for the IV clot busting medications. So we get that history quickly. You get IVs placed. As soon as you can, you get to CAT scan. You remember how we said 80 to 85% of strokes are ischemic, but 15 to 20% could be hemorrhagic, sometimes more in metropolitan areas. So getting that CAT scan is crucial. And it's actually one of the metrics that certifying bodies use as well to see how well we're doing. So you get a CAT scan. No hemorrhage. You're within a window for thrombolytic therapy. Your story that you've given us tells us there's no contraindications. Bam, go. Give that medication as soon as you can. Medication's in. Maybe they're not a candidate. We need to know if they have a large vessel occlusion based on what you've told us and based on the early exam that we get in the ED. We're going to get that NIH stroke skill. We're going to get it super fast. We're going to know pretty much just from a look at the patient of whether they're having a large vessel occlusion, but we need to get an idea of that first. Then they get vessel imaging. Really important because the studies that failed in thrombectomy early on in the 2012-13 era didn't use any vessel imaging. And that's why they failed when we analyzed them afterwards. So a CT angiogram, an MR angiogram, as long as you can get it quickly, make sure there's a vessel occlusion. CT perfusion, if somebody has been having symptoms for a longer period of time and we need to assess those backup pathways that we talked about, is next. All again, time-sensitive studies. And all in the background while this is happening, a stroke team, a neurologist, a telestroke service is anxiously waiting for those images to come, so we can do it real time. We also have neuroradiologists in the background reading. So it's like that pit crew mentality, all hands on deck. We're doing this to make sure that we can salvage this brain as fast as possible. If they have a large vessel occlusion, the interventionalist is called immediately, and our team gets in. And everybody has criteria, even on our end, for speed for getting in. That's a requirement to get in as fast as you can. They get in, a very quick evaluation. They get to our room, and we attempt to perform the thrombectomy as fast as we can. So that's the mentality as far as the upfront care. Care doesn't stop there. It continues on in a neurointensive care setting because the postoperative care is just as important for these patients as far as blood pressure management and new medications to make sure they don't have another event even after this. So all of it happens very quickly, but it's organized chaos is the best way to describe it.
So the early administration of lytics is pretty quick. I mean, they go in, they see, hey, it's a positive stroke. It's not blood. There's no blood in the head, so let's give lytics. So I mean, that can be pretty quick. I mean, even sometimes less than half an hour. What's that same time measure for thrombectomy?
So the guidelines right now are still in formulation. The recommendation is if a patient comes through an emergency room, if a hospital that's a comprehensive stroke center or a thrombectomy capable center, they come directly in, have never been evaluated outside, they came straight from the field to our ED. The guideline says we have 90 minutes, essentially, to get that patient for an arterial puncture in the leg. 90 minutes. So that allows us time to get IV thrombolytics, get teams together, get imaging, get them to the room. Everybody's allowed to come in at 2 a.m., 90 minutes punctured into the leg or the arm on that. Then you have about at least 60 minutes from that time to open up a blood vessel. If a patient presented to another hospital and they need to get transferred, well, they've already been clinically evaluated at that point. So if they're transferred over to us, it's no longer 90 minutes. It's 60 minutes at that point. Sorry, we blanked out there for a second on my screen. But 60 minutes at that point. And then again, another 60 to get the clot open. And these are actually, they sound like a long time, but they're tough metrics to meet because of the off-hour cases. And that's true across the board around the United States. Those are the most difficult ones to do off hours. But that's the goal, to get it open as fast as possible. Our fastest times here are around 4 to 5 minutes for recanalization. Our times average under 30 minutes, but you want to get there in 60 minutes ideally to the clot and removed. Now, it's a relevant question because as we're doing more complex strokes, as we're doing these medium vessel occlusions that are further out, I feel that these time metrics are also going to change a little bit as well. They're not going to be a one-stop shop to say that number works for.
And the reason I wanted to ask that is because for the EMS clinician, for our listeners, this highlights the importance of getting the right patient to the correct destination, right? If they meet that, so in Maryland, it's a LAMS of 4 or greater, the amount of time that it takes within the hospital really shows EMS how much time we save if we get the patient to the right hospital in the first place. I couldn't tell you how long the average intake may take, right? But that's all time added on the front end of a procedure that for you all has to be done within 60 minutes because they've already done a lot of stuff at the front end. But if there hasn't been anything done in the front end, it's 90 minutes. So what that tells me is if you get the right patient to the right place for these thrombectomy procedures, you're saving the patient a ton of time, because I guarantee you from a patient entering the inappropriate facility to them getting to your door is way more than 30 minutes. And that's the gap that you all have been given for if they arrive to you primarily or if they arrive to another outside hospital and then come to you. So it's super, that really comes to stress how important it is to get the right patient to the right center at the right time.
Yeah, it's a great point, Mustafa, because this is why the tiers exist. And I remember my very first certification I did for Comprehensive Stroke Center at the time. The thrombectomy capable stroke center certification didn't exist. It was either primary or it was or it was comprehensive. There was a primary plus built in at the time, but it was one of the two. And we realized quickly that that doesn't really encompass the access that's needed for a lot of patients in a lot of areas. So that's when the idea of thrombectomy capable came out, and it launched like no other. A lot of PSCs converted over. Here, we were a TSC for about a year to make sure that we had a good catchment of those patients that needed it. And now we're a CSC at MSR Franklin. But without that TSC designation, I think we'd be missing out on a lot of patients receiving that urgent time-sensitive thrombectomy.
Yeah, go ahead, Josh. Go ahead.
So just to kind of clarify on the time frame. So you said for those coming to a thrombectomy capable center, we're looking at a 90-minute time frame. And just to rehash, that's 90 minutes from door to needle?
Door to puncture.
Door to puncture, okay.
Yeah, so that's not the needle, because I know it's confusing. The needle time, as it comes to our metrics from the state and from Joint Commission, refers to the needle time for IV thrombolytic therapy.
Okay, so door to puncture.
Yeah.
So, we're talking about clinicians getting patients to the right places. Looking at the list, the number of clinicians in the state that have this capability to get to these places is pretty limited at the moment. It's an avenue in the state, basically. I know I benefit from it from my work, but where Moose works part time, I don't know if Christiana is thrombectomy capable, but if you're on the lower end of the county, that's going to be a difficulty because you're kind of in a crapshoot there. But if you're on the Eastern Shore, if you're in Southern Maryland, that's where these like transfers are coming in. So that 60 minutes. So the people that are out on the shore, they have this patient, they're lambs of 4 or greater. What is the likelihood that this patient is going to have a favorable outcome coming from, let's just say, Easton? They've got a 30-minute drive into the hospital. They've got their time at the hospital, and then Easton's got to call, I don't know, PHI or STAT or whoever, MedStars helicopter, come in, pick them up, and then bring them up to Franklin Square or somewhere else. What does that look like for those people? Because I don't want us to cater just to those that have this ability to get to a thrombectomy capable center, because I'm sure there's plenty of people that are listening that don't have that ability.
Right. No, it's what a great point, Josh, on this, because there are centers that are outside of that range. And as a state, the other hat I wear with Kenny is I'm currently vice chair of the MIMS Quick Group. And so we're looking at this, and we realize that not all centers have this. It's also worth noting this metric that we talked about, 60, 90 minutes. It's stuff that is all for certification, that it all comes back to getting it done sooner and as fast as you can, right? So even if you don't hit the 60, as long as you get to a spot that you can get it fast as you can, the chances of a meaningful outcome are much better. And this is where we're learning more and more about this every year that goes by, because we're finding that patients might benefit beyond the 24 hours because their backup pathways are better than what we think. And it's all a picture of that penumbra that we talked about. But let me come back to what you were saying about, let's say, the Eastern Shore or other areas. So currently with EMS in Maryland, there's a 30-minute window, right? So, or a 30-minute range for getting to a center for it. We're in the process right now of doing another pilot study. We're working on the logistics of an IRB behind it, to expand that to a 45-minute window, which I'm sure you guys have heard as well. And the formality of getting into IRB, we still need to work on. We're very close. And so we have a list of hospitals on your sheet that are within that 45-minute window that will essentially be preferential to say, hey, you should go here within 45 minutes to get the care you need. But on the sheet, there's still a significant area of patients in hospitals that aren't even in there. They're even beyond the 45. And what I say for those is you still just need to get to the place fastest. helipads, right? We have a helipad here. Maryland, Hopkins all have helipads as well. We're all CSCs. Use that when we can, of course. Obviously, we're limited with flight, sometimes with the weather. But use that because that's going to significantly decrease those times. But otherwise, as you guys know better than I, license sirens as fast as you can, get there, and then you still need to get to that closest spot, even if it's not within the 30, 45 minute.
Awesome. And I guess this is also the built-in that 22-hour rule that's in the protocols. Like, hey, get them to the definitive care and let you guys determine, like, hey, this is going to be a go or no go situation, but do our best to facilitate that that transport and making sure that is just complete, at least on our end.
Yeah. And, we want patients to get here as fast as possible. We want a favorable port to penumbra ratio.
Mm-hmm.
Other thing that we've learned in the past couple of years is that patients with a much, much larger core than we originally anticipated still do better than expected. And so there's another subgroup of patients that are called large core stroke patients. Those that have that pink area that's almost the same as the green area that still do very well. So still getting there for evaluation early might still put you in room for candidacy for not maybe IV thrombolytic therapy, but for a thrombectomy.
Let me ask you this. I just thought of so say I have a patient who, and I know we've been very Maryland centric for this episode, but especially for some of our listeners, in the Midwest and beyond, in extremely rural areas of the country that may have hours close, towards their closest thrombectomy capable comprehensive center. How should I ask this? The time limit for lytics is still around 4 hours, correct?
4.5, right?
Yeah, okay. So if you have a patient that's outside of the window for lytics, but within the window for thrombectomy, that has a LAMS less than 4, how do you approach that patient? Because I've personally had patients like this. I've certainly heard of cases where folks are encouraged to still transport to your hospital. How do you manage that risk versus reward?
Yeah. This is where I think the centers of excellence, the thrombectomy capable centers, the comprehensive stroke centers, are the place where patients need to get triaged to lower scales. And if you'll let me share a couple more things, I think this point that you're saying right now is very, very pertinent on here. And these are the medium vessel occlusions. These are the patients that don't have that LAM score, but still have disabling deficits. And I think that those two words right there are the ones that we always want to hone in on. Disabling deficits. Somebody comes in with severe weakness on one side of the body. They might not hit all the other criteria for LAMs on there, but they might still have an occlusion that needs to get evaluated and probably needs more specialists in an ICU setting if they potentially would need a thrombolytic or a thrombectomy. And those are those centers of excellence for it. There was a patient that we had come in that was actually transferred in who, and I'll show the pictures in just a second for this, but came in from another hospital. And the word that we got from the other hospital was there was some sort of middle cerebral artery occlusion, but his stroke scale was pretty low. And it was hard for them to objectify exactly what it was. And the deficit was difficulty with speech on that, but it was a low scale. They could move everything. They were full strength, but speech is a very disabling deficit. And so you have a low stroke skill. I mean, if it were me, take me to a center where I make sure there's not something that can be done on that. And so that's what we did for this patient. And I'll pull up the pictures just to kind of show you what we found on their imaging. And let me just go ahead and share this now. So just on this slide here, this is we got a CT angiogram. They came here and what did we see? Difficulty speaking. And what you see the arrow pointing to here is the middle cerebral artery, but a branch of the middle cerebral artery. So not that large vessel occlusion. This is that medium vessel occlusion. And he was still having trouble speaking, so we got one of those perfusion scans, and it looked like this. So we're not seeing that massive green area I showed you on the other patient, but you're seeing a huge difference between the pink area that's dead and the penumbra. That ratio is 16. And with that being a disabling deficit, I am so glad that he came to us, because here's what we saw when we took him for thrombectomy. Same blockage we saw in CAT scan, but looking at the patient from the side, the lateral view here, that area inside that oval should be filling with blood vessels, and it's not. It was a massive perfusion area leading to his deficit, even though the stroke skill was low. So we treated him just like any other patient. We did a thrombectomy, and here are some shots actually of those devices that we actually used. And this is a little more magged up. You can see it. This is that stent retriever here with a vacuum tube right behind it, the catheter on here. And we were able to restore his blood flow to that area. You can see the before and after here. Left with a stroke scale of 0 and no deficits. And there's the small little chunk of clot that came out with that stent on a stick that was there. And when I saw this guy in follow-up, it was hilarious, because his wife said that he spoke more now than he ever did before he even had symptoms. And so, these little stories that I'm telling you about tell you how a small little clot can lead to a decent perfusion deficit and be life impairing. And so we take those just as seriously for getting to those centers, even at lower LAMs or lower Cincinnati's or lower NIH stroke scales.
And for the listeners out there, I know, if you're only listening on Spotify or wherever, you didn't get to see that. I highly suggest you go to the YouTube whenever we get that up and take a look at what was shared at that point. And it is quite amazing how much space was occluded off and how much was affected. So just to get a good visual representation, understanding what Dr. Singh was just talking about, definitely go take a look.
Yeah, it's really interesting to me, Dr. Singh, what you're talking about. And one of the biggest themes I've picked up in our discussion so far is that the landscape has changed, but it continues to change. Could you describe a little bit about where we're going in stroke care? At one point, you mentioned that there was a tool that hospitals use that utilize AI. So could you talk about that?
Yeah. So these pictures of perfusion that you were showing, these pictures of showing the blockage, AI is huge right now. There's lots of companies that have been working on this for a few years now, and the technology, if I showed it to you, is wonderful. It detects the occlusion on there. It uses AI to essentially, with using deep data, looking at hundreds of thousands of images over the years and learning from them to see what an occlusion might be. It'll tell us when there's an occlusion there. And the apps are built in now where they'll alert us at 2 a.m. with a really annoying sound to say, oh, there's a blockage here at such and such hospital. Get ready for more information, of course. The perfusion will come up there too. It'll notify us. And these apps actually are now used sometimes to notify our teams. And so as soon as that alert comes up there, we'll start activating our team internally so that they know to get to the hospital. That's just as critical. If the team's not here, you can't do the procedure. When these AI systems, these apps first came out, and we plant them in large systems of care, large hospital networks, and we were just starting to learn about them, the AI would definitely detect the occlusion before even a radiologist sometimes was able to look at a picture. And so we wanted to get ahead and see how well it worked. We would call the referring ED, the one that the image was taken at, and say, do you have such and such patient there being evaluated for stroke? And said, yes, we do. Well, they have a large vessel occlusion. We need to get them over to our hub right now so that we can help them. Can you at least get your ED doc to make sure the story is consistent, or what have you, or a neurologist that was there? And I'll say, even in MedStar, in the early stages of our program, we were doing that with a lot of our sister hospitals, where we'd call the ED and they'd be like, yeah, how did you know about that patient?
So it's like a reverse consult.
Exactly. Right. A reverse consult, Josh. And it was great though, because it shaved off so many minutes because we were proactive with it. So the AI is constantly developing with this in helping our eyes not to miss things on here. It goes beyond even stroke, and it's going into a lot of neurosciences and beyond neuro, in fact, on it. But that helps us get there faster. Anything that can help utilize that tool would be great. We're working on algorithms with companies now to help, even on the EMS side, to help bridge that gap and even make it even faster. Because if you have access to that app early on, it'll help notify us even faster. And this, hopefully those come to fruition in the next few years. That's not just in Maryland, that's beyond Maryland as well. And then outside of AI, the field, where's the field going? You mentioned R&D and technology is flying by the seat of our pants right now. The catheters that we use are getting softer, more pliable. They can get to spots that we can never get before. The devices are getting safer. We're able to do this with less risk in these patients. And as we're learning that more patients benefit with more core, we're able to offer it to more patients. So I think that's the direction that we're kind of heading, where this is going to be available to more patients than we initially anticipated.
I got to ask this question, and I know it might be a little bit of a difficult question. So whenever I think about stroke, heart attack, cancer, diabetes, I think the saying that an ounce of prevention is worth more than a pound of what is it? Man, ounce, I just blanked on the others on the end of it, but people know what I'm talking about. What are your thoughts on how we prevent that patient from even getting to your table? What can we do? I mean, certainly we're not going to cure metabolic illness overnight, but what are your thoughts on that?
Yeah, it's huge. And I'll say in other arenas in neurovascular disease, there's some areas where we're actually seeing less incidents over the years of, say, subarachnoid hemorrhage in that population. And I think as public health measures improve over the years, as we get more awareness out about primary health conditions that can put you at risk for stroke or hemorrhage in the brain, the hope is that we can avoid these things. But we're never going to avoid everything. And the other side of the coin for me is well, first and foremost, preventive care is huge. You want to see how you can stop this. But as you guys both know, stroke can happen to anybody, even without risk factors. And so awareness of what stroke looks like in the community has been another piece of the pie. We do it through MIMS. We do it through other avenues with Stroke Smart Maryland and Stroke Smart other states. We're working closely with those organizations so that everybody kind of sees and understands what those signs and symptoms of stroke might be, and that calling 911 and getting you guys to evaluate those patients initially in the field is so important to getting them where they need to be. So I think it's two sides of that coin. One is that preventive side of not even letting it happen or decreasing the incidence. But the second is community awareness.
I think I've also learned from this episode that if I ever go to medical school, I can't go to radiology because an AI is going to take my job. Or just skip to interventional radiology. I don't know.
I think radiologists will always have a job. The gold standard that all these AI platforms look at is still comparing it to a neuroradiologist. So I think we're always going to have a need for those radiologists. But yeah, it's funny. We joke about that sometimes, of which jobs are going to get taken first. Listen, we have robotics that's also of age coming in our field. And, cardiology is working on it first. For every step forward, there's a couple steps back in this area too, but we're still in the early stages of robotics doing this, where you can remotely do angiograms or remotely do procedures. And trust me, nobody's job is safe.
Yeah. And I mean, I think all of us would agree that should never be the step that, or the reason that blocks us from progressing in medicine, right? I mean, so again, going back to the beginning of the show when I talked about my experience at that conference I talked to you about with the gentleman that presented on thrombectomy and that number needed to treat. This is remarkable, right? I mean, I've had family members that, passed away from severe complications of having a stroke. So the fact that we now have technologies that can have someone that can't talk, like your patient, to being able to walk out of the hospital or leave the hospital with no symptoms, that's amazing to me. And EMS, to me, and I think it's self-evident, is a critical piece of that chain of survival for these patients to get out with positive outcomes. Josh, did you have something? I think I might have cut you off.
No, I don't have anything. I do agree that there's been a lot of change, and a lot of change for the good over the past 17 years for me doing this, and seeing the changes and seeing the outcomes, and also having my own personal stories with family members that, one, if I remember correctly, my uncle went in with an occlusion that ended up then turning into a hemorrhagic in the hospital, and ultimately passing about a week after the entire event. And it's just, that was 2007, 2008. And, to think of where we've come from there, the constant number changes and how we're seeing better and better care. I know in the hospitals that I transport to, it is very hands-on by the care team as soon as we walk in the door. That's a change. It was usually, we'll just, right to CT. We're not going to do anything else. We're just going right to CT, not the whole hands-on NIH scale, and let's get lines, let's get labs, let's get everything done, and then determine what to do, and then be ready to treat this patient as soon as they come back from CT. And then just to, kind of nerd out on medicine, to see the old become new again with next plays coming back into play. That's pretty cool. It's just like figuring out things are working better than other things that we were doing. And it's just awesome to see this care, because I think this is some of the stuff that we see. We don't see it, but we may hear about it. Our biggest influences on patient survivability and outcomes. Like, we can treat asthma attacks. We can, treat a bunch of different respiratory cases, but STEMIs and cardiac arrests and strokes, that's like where we're seeing like our biggest change in survival over the years. And it's a rapid increase. Just like I said, 17 years ago, completely different game. And now it's great. It's great to see. And I love this talk about stroke and the talks that we have and the ones that we have planned, because it's a huge area of influence in EMS.
Yeah. I mean, Josh, you have that personal story. You've gone through this from a family level. It sounds like, Mustafa, you did too, at some point. And you said it was 2007. And back then it was funny because that was just in the era where we're having these young devices like the Mercy device. And it was one of those things that I was still in training at that time. And I would be in the angio suite using these new devices with my mentors. And you'd take one or two passes and it didn't work. That was it. You're like, okay, I tried, it didn't work. We did the best we could. Now, if you're in the angio suite and you don't get a clot open, you feel like you did something wrong because the devices and the technology are so good. It hits you right here because you feel like you should be able to do better with the technology that we have there. And it's hard because, no matter how many hundreds of cases you do, you always want to restore that functionality to each patient, and even more so the family, because that's a surprise to them each time. And so when we have the luxury of seeing these patients in follow-up in clinic, and many of them are coming back in, some of them don't even know what happened, but their families do. They remember it vividly. And every single time is different. Every single time it gives you a better appreciation of why you're kind of doing it.
So something it just popped in my mind about like the changes and the stuff that we see. Nothing to support this at all, I'm about to say, but it just feels very anecdotal. That I see a lot less previous TIA, CVA, and hemorrhagic stroke patients that we run into later on down the road for another reason, and or possibly a repeat neuro event, that don't have deficits, compared to, I'll say, the first half of me being an EMS. Massive change. And like you saw it all the time. You go to nursing homes and prior stroke patients, massive deficits, didn't recover even like a whole side of the body, anything like that. But now, I just had one last night. She was under a week since her stroke, and had her for a single episode that kind of looked maybe neuro, maybe was cardiac, not sure, but zero deficits. And it's obviously not uncommon, and it wasn't uncommon 17 years ago when I started. But I feel as though I see a lot less patients that have no deficits, unless it was a major event, or it's like, oh, the stroke was 12 years ago. Okay, yeah. But if they're within the past 10, maybe 5 years, it's been totally changed.
That's nice to hear that you're seeing that in the field.
I think I agree with you, Josh. I'm trying to think of all the yeah. It used to be all the time. Like my aunt had I think the primary event that caused it was a brain tumor that then I think I was very young, but then that caused somehow she had a stroke. Or no, she had neurodeficits from that, but then she also ended up getting a stroke. And then the interesting thing with her was due to mental health, she stopped being compliant with her anticoagulation, which then caused her to have another stroke again. But apart from my aunt, so I mean, yeah, when I think about patients, I think that might be a testament to how our stroke care is improving, right? And how maybe prevention is getting better too. Yeah, I don't know. Dr. Singh, did you have anything else you wanted to cover tonight? Anything that we haven't talked about so far?
No, I think you guys have done a nice job of showing this. In our state here, we're trying to actively work on access and making sure, like Josh, you had mentioned earlier, making sure all hospitals and all networks of rural areas have access to stroke care. I think that's going on nationally as well. Every rural area, every pocket of area geographically that doesn't have true access to a center, the centers that are closest are trying to find a way to give those regions access, whether it's by air, land, or there's another methodology that we're using actually in New York City when I was in practice there, is the trip and treat model, where the interventionalist goes to the facility. The facility is actually set up to actually do a procedure there, but the interventionalist travels there to decrease the amount of time. And so, thinking outside of the box, I think, in a lot of these areas is crucial to increase that access on there. We've talked about it over here too. It requires some manpower. And, this is where that AI, let's say you have a robot somewhere, this is where it's going. And I think it'll be great to house some of these things at places where traditionally patients won't be able to receive that acute care. We'll have to find a way to do it.
Wow.
Awesome.
That's awesome. Josh, did you have anything?
No, I came in a little late, but still, it was great talk, great information that I think the listeners are really going to appreciate. But thank you very much, Dr. Singh, for coming on and talking about this and even enlightening our own minds. And yeah.
Well, I appreciate you guys having me. It's a passion, of course, but it's nice to just colloquially talk about it with you guys as well over here today. So thank you.
Absolutely.
Take it out, Moose.
Yeah, absolutely. The only thing I'll say is before you close this out, folks, if you're listening on Spotify, or if you ever listen on Spotify, please follow us on Spotify, because that's helping us a ton. So that's all I have. Josh.
Okay, awesome. Like Moose said, follow us on Spotify. I'll also say follow us on all of our social media, Facebook, Instagram. Always stuff coming out there. Wherever you are, have a good morning, good evening, good afternoon, good night. And thanks for listening. Be safe, and we'll see you next time. See ya.